Well, thank you for staying with the course, folks. I am going to be the last speaker for the day. And I want to pull in a bit of what we've learned about today. Today we've shared lots and lots of information. We've learned a lot from everybody else that's in the room. So I am going to ad-lib a bit of my slides. So it talks about connected care, past, present and future in care homes. I'm not interested in the past in a way, because care homes didn't always connect that well. We've talked about the AHSNs. What we haven't talked about is complex patients. So what we've talked about, certainly this afternoon, are all those patients that go in and out of hospital. And then they're abandoned often within either care homes, at home. And Mark, you heard this morning, said, I went home from hospital and that was it. I was left on my own. And what we see with those patients is they exacerbate their long-term conditions, and we're not monitoring them. We know that over 40% of patients that are discharged go out with either a long-term condition or become more dependent on us as carers to look after them. But what we need to do is how can we help these people in their own homes? And our mental well-being, if nothing else, COVID has taught us that we really do need to start thinking seriously about this. And patients are even more isolated now than they often were before. And those follow-up services, like you've already said earlier, some of them are just starting to happen. So there's a whole chasm of people left on their own that we're not necessarily looking after, perhaps as well as we could, but is that because we've not been enabled to, or not enabled people to? So we talk about the Enhanced Care Home Framework, and this is a huge programme that's running nationally for care homes. It's been talked about over the last few years, and it's really starting to come into play now for those of you that work across primary care. We talked earlier about the DES contract and aligning care homes to GPs, to having PCN networks, we start to think about holistically in how we look after patients and not put everything in a silo. And deterioration sits alongside that somewhere, usually on the corner, along with the growth of technology. So we've linked care homes up over the last 18 months with data protection toolkits, with NHS Mail, with the facilities to be able to go onto learning platforms, like you heard earlier from Health Education England. That would normally be a subscribable process for care homes to have to spend more money on, really. And we want to keep people in health and social care. And it's a massive challenge. I know Anna has already said it's the elephant in the room that often we haven't always taken that challenge on. And we are starting to take it on now. Again, we talked about remote monitoring in care homes. And this slide's slightly different from the other one in that it starts to talk about how we can do this digitally, how we can enable staff to use equipment that's starting to come on the market, and there are several. What I have noticed with them as they start to go through the AHSNs, and that's where we can really start to vet some of this equipment that comes onto the market and enable people to use it, but also support the innovators to design equipment that users can really make good use of without having to learn a lot about it. So we want them to be user-friendly, we want them to be plug and play, and we don't want to make it any more challenging than it really needs to be. And we've started to do a pilot with a piece of equipment that we hoped did just that, and we did a bit of designing and redesigning in the process. And there are several coming to the market now. All of them are now NEWS compliant, whereas previously they weren't. There was only ever one on the market that actually had NEWS on it. And right at the beginning of COVID, that was a real challenge. For us in the pilot, we had 35 homes across the eastern region. It doesn't seem many, but when you're starting from nothing, that's better than nothing. And it was part of the Innovate UK grant. What we could do with virtual training, and I know you all work virtually now, is that we had a kit with me, and I would have that kit, and I'd be teaching people how to do it. So it was very much see one, practice one, off you go, folks. That was the best we could do, but again, it was better than nothing, which is what was there before. We saved hundreds of miles, and if you put that into a calculator, that's 3/4 of a tree. It's nice for me, nice for my organisation that also didn't have to pay my mileage costs. And for engagement, it's what we've done recently. We've had a lot of work. We've gone directly to care homes, And that work stops there. What we want to do is engage everybody and have that common language and create that. So we sadly had to start at the top, and then we flowed that through our region, through their networks. And so far, it's working. So we've learned a lot as we've gone along with this, and we talked about PDSA models earlier and sequential learning, but how we've scaled up this programme. So we've now gone from our 35 homes to 500 and something homes with an additional mental health units in there as well. And we've now started to put this in homes with people with learning disabilities. And what it has done is had that, not an adverse effect, but a very different effect than one we wanted it to have, in that it brought people together. In those virtual sessions, some of our care homes had never really talked to each other, so we encouraged them to meet and have a cup of tea and talk about how they were using this equipment. For those people with learning disabilities, when they went into hospital and met you, some of you at the front door, to have those observations taken was normally a challenge. For them, they've got the opportunity to keep practicing with this. We encourage our homes to use them in their residential homes, so we encourage them to use them once a month and become part of the weekly ward round. And again, that's another piece of work that we are working on. It's not going to happen overnight, but it has happened an awful lot quicker than I ever thought it would. The dashboard is the one I showed you earlier, but again, you can use that for the multidisciplinary teams, and it will take photographs and other assessments. The same as creating sustainable, safe solutions. This is a work in progress. It's not a fix. It's going to keep evolving, and we want it to keep evolving. This is where we can really get some really interesting work. So across our region, these are the homes that we started with, and this is where we've scaled up, and it's been scaled up at pace. And we've been able to do that, again, through the networks and through a lot of the meetings that we can manage to do online. We can reach all the teams for these people so much quicker than we ever could before. But the other thing we've managed to get that we've never had before is data. And that data is coming from the news data from that originally, that piece of tool that we've got now. But that data set, the architecture behind it, you can use any piece of equipment with news on it. And that comes into the AHSN, and we measure that data against ambulance activity, see and treat, but also how many days are those beds left open in care homes, rather than the days that they're taken up in hospital. Because we've never really measured social care. We do a lot of measurement in acute care. You've heard about it all day. We've never managed to do that within social care. So all of these homes that are on this data set are using news scores. What you will see, and this is how we've reset the system now, is right at the beginning, you see the difference between the observations taken and the news scores at the bottom of the screen. And that's because the system allows them to take just a blood pressure or just a pulse, or for COVID oximetry, we could just monitor COVID oximetry. What we want to encourage people to do is to do the whole news score. The reason it was set up separately is so that we could use it for all those different circumstances that care homes were about to meet over the last 18 months. But where we will change that and where it'll grow is we will hope to see on the graph on the bottom of the right-hand corner is we will start to see a lot more of the news scores. We will expect to see 1s to 3s, but what we don't ideally want to see is those red 7s. And those 7s, if they happen on a Saturday and Sunday, we can drill this data down to care home managers so that we can provide them with that and their SPC charts so that they can start to do continuous improvement. So why did we have that one outdoor spike on a Saturday night? Was it staffing, or was it, what's caused that? And they can start to look into that variation and do their own quality improvement. And I know people all want to go home, but what I want to leave you with is people living at home. So for me, this is around soft signs of smart houses. So just imagine if, for me, my parents are elderly now and fortunately don't live that far away. But when they're on their own and they're separated on their own, they have a behaviour pattern. Now, if I could monitor that behaviour pattern, I'd know if something was happening to them. There is such a thing as a water meter that you can just pop anywhere in your house. But if your relative put the kettle on every morning at 6 o'clock, went downstairs, opened and shut a door, and you got a monitor on that door, and that didn't happen, and they text you, the machine texts you and says, actually, that hasn't happened today. To me, that's a soft sign. Wouldn't that be brilliant if we could start to have that in our houses? Now, it's all out there. There are sensors for your doors. There's sensors for your fridges. There's sensors that if you've got wandering relatives that go out of a front door, that will speak to them and tell them to turn around and come back. And then they'll ring you. What the challenge has always been is, Big Brother's watching me. But Big Brother isn't watching you, because actually you own that data. And that's where it gets really clever. So own the data, but also help people live in their homes for as long as they possibly can. And when they can't, at some point we will have a national record library where we bring all this information together. So we start doing planned care, and we can plan it at any point in our lives rather than wait until we're frail, we're elderly, and we don't want to do it. I'm sure there's people in the room, for the mortgage owners of you, have probably been asked to write a will at the same time. Not everybody does that, and in the will, does it tell you where you want to go at the end of your days? We've seen, I don't know how many adverts on the telly at the minute where you can make your last wishes known, and you can put some money away for son or daughter, or play for your funeral. But we never ask how we want to end our lives, do we? We never ask where we want to be at the end of that, but we do ask who's going to pay for it. It's all a bit odd to me. So I want to leave you with, what does gold look like? And to me, this is what gold looks like. These are where the new housing estates could really start to think about how people are living them better, but not be as obtrusive as they could have been. And finally, I'm going to introduce you to Paul, and I'm hoping this plays, because if today's gone by anything else, I'm hoping it will. So Paul Paul's just the reason I think we all get out of bed in the morning. I really do. Hopefully it'll go. Here we go. But we haven't got any sound. Yes, we have. Perfect.
Your blood pressure is 121/67. Your blood oxygen is 96%. Your pulse is 60 beats per minute. Temperature is 36.4 degrees Celsius, 97.5 degrees Fahrenheit.
What I can tell you is it took us about 30 minutes to film that, because Paul was probably a bit like me and doesn't stop talking.